Thank you, Luce, and welcome everyone to one of our eUROGEN educational webinar series. Before we get started, I'd just like to take a couple of minutes just to explain a little bit about what eUROGEN is and does. Well, we are one of 24 European reference networks created by the European Commission in 2017, and we enlarged in 2019, and we're now 57 hospitals, the expert teams working in those hospitals across 20 member states. And really what we're aiming to do is to share knowledge across the network for patients with rare urogenital diseases and complex conditions, both pediatric and adult. And some of our activities are, well, we do virtual cross-border consultations using a secure platform provided by the European Commission called the Clinical Patient Management System. And this enables us to connect our experts working across those hospitals, and they can have case discussions on difficult cases. So please feel free. This is a service that's open free of charge to any healthcare professional working in a EU, it must be an EU or an EEA member state. So we can provide this expert advice from multiple experts if requested. So please don't be shy, do contact us via the website if that would be of help. So along with the virtual consultations, we have education and training activities like a clinical exchange program between our healthcare providers. And we also have a EUROGEN registry under development, where we hope to be able to track patients with rare and complex urogenital diseases over 25 years. So that should really help learn and inform research going forward in the future. So without further ado, I would like to introduce this evening's webinar. It's Transitional Care in Anorectal Malformations, the State of the Art. So we have three presenters this evening. We have an-Hendrik Gosemann, who is a pediatric surgeon at Leipzig in Germany. And we also have Paola Midrio, who is at Treviso in Italy. And then finally, we have Dalia Aminoff, who is with the AIMAR patient organisation. That's the Italian patient organisation for anorectal malformations. And of course, she is the chair of our EPAG. So Dalia has been involved intricately with the network since its very beginning. And this webinar is produced in consultation together with ERN and also the European Pediatric Surgeons Association. So thank you everyone for collaborating, and we really look forward to hearing what the absolute latest state of the art is for anorectal malformations. Over to you. I think, Jan, you have the floor.
Thank you very much, Michelle. Ladies and gentlemen, thank you very much for joining our EUROGEN webinar on transition care in anorectal malformation. My name is Jan Gosemann. I'm from Leipzig, and in the next 10 minutes, I'm going to set the stage for Dalia Aminoff and Paola Midrio, and I'm going to talk about, let's just forward this, sorry. I'm going to talk about outcome measures and health-related quality of life in anorectal malformations. So from a surgical perspective, fecal dysfunction and urogenital dysfunction are the main outcome measures in anorectal malformation. We know that incontinence and constipation determine the quality of life, and it has been shown that impaired bowel function has a negative influence on sexual function and quality of life. What determines the continence prognosis in anorectal malformation? So prognostic factors are the type of malformation, associated sacral anomalies, and associated spinal anomalies such as tethered cord. And from case series and from registries, we know that there are different continence prognosis for different types of anorectal malformations. For example, the perineal fistula has a better continence prognosis compared to patients with a bladder neck fistula. But what about the long-term data? The group around Stefano Giuliani performed a systematic review in 2016 regarding looking at 455 patients older than 10 years in the time frame from 19 1994 to 2015. And the authors found that during the transitional period, the incontinence rate was 31 to 70% overall. However, in adults, it seems to decrease. The incontinence rate was 24 to 46%. And as stated earlier, Stefano and his colleagues also confirmed that low anorectal malformations have a lower incontinence rate compared to high anorectal malformations. The Swedish group around Thomas Wester performed a single center study, which was retrospective. They looked at 136 patients with anorectal malformations and compared them with 136 age-matched controls, and they handed out questionnaires regarding bowel function and quality of life. And what they found was that patients with anorectal malformations have a significantly higher rate of impaired bowel function, which is obvious. They have significantly more problems with need to rush to the toilet, soiling, and use of pad during daytime. They furthermore found out that impaired bowel function, as we heard earlier, has a negative influence on sexual function and quality of life, and they concluded that patients with anorectal malformation should be offered a structured follow-up into adulthood. But what is a structured follow-up, and do we have such a thing? Again, Stefano Giuliani and also colleagues from Italy, Pietro Bargolan, Giovanna Ricci-Pittoni, and Ernesto Leva, performed a survey among delegates of 2 colorectal meetings in 2015, which was published in 2016. 96 surveys were included, and the majority of the respondents came from the EU and were consultants. So the surgeon's perspective showed that, as hoped, the majority of respondents followed their patients until the age of 18. However, I find it alarming that 33% of the respondents don't follow their patients up until the age of 18, but latest until the age of 10. And furthermore, 82% of the respondents stated that there are no multidisciplinary meetings with adult practitioners and a transition coordinator, and 72% stated that there's no protocol to transition ARM patients to selected adult practitioners. So there's a huge variation in practice regarding long-term follow-up, assessment of active issues in teenage patients, and transition of care. And the authors concluded that long-term follow-up and management of ARM patients should be homogeneous, measurable, and comparable at an international level, that healthcare practitioners should work together with family support groups, and they should actively involve adult practitioners in the process of transition of care. What about the patients and parents' perspective? Dalia is going to talk about this in a minute, but I want to introduce at least 2 studies from Dalia's group. This is a survey and questionnaires regarding quality of life in Italian parents and patients with anorectal malformations. 209 patients were included from the age 1 to 45 years. And the patients stated that only 40%, or the parents stated that only 40% of the patients operated with an anorectal malformations were followed by the surgeon who performed the primary operation, meaning 60% of the patients were not followed by the surgery who performed the primary operation. Furthermore, 55% only were given an explanation about the child's malformation prior to surgery, and again, 55% of the parents only did receive information about the functional prognosis at the time of surgical reconstruction, which is again alarming from my point of view. We know that there's a high frequency of mental and psychosocial problems in anorectal malformation patients, and Dalia's group found that the lack of psychological support is present in 74% of the responders in their study. Another group from the AIMAR organization was again a survey and questionnaires regarding the quality of life at 2 different time points. So 134 patients and parents were questioned at the age of 2 to 11 years, and 6 years later there was another question round of 73 patients aged 8 to 17 years and their parents. And the group found that continence improves over time, which has been shown earlier by the meta-analysis. But however, emotional functioning, social functioning, and body image areas of quality of life significantly decrease over time. So the authors concluded from their data that early interventions focused on the individual emotional and social responses to the ARM condition and aimed at preventing body dissatisfaction may or even should be implemented. Our group performed a review of the literature regarding health-related quality of life of anorectal malformations and Hirschsprung's disease, and we could confirm the key factors for influencing health-related quality of life in anorectal malformation patients, and we can also confirm that those are impaired in these patients, which are bowel function, urinary continence, sexual function, fertility, psychosocial function. So taken together, follow-up should be structured and not only focus on surgical outcome, but also on psychosocial outcome. We need a multidisciplinary follow-up, and we think that the development of consensual clinical practice guidelines is definitely needed to improve the quality of care for anorectal malformation patients. And this is why eUROGEN set out to develop European ARM guidelines. And here you can see the lead of this group, which are 3 healthcare providers, including Ivo de Blau, Martin Lacher, and myself, and 2 patient representatives, including Dalia Aminoff and Nicole Schwarzer. And we included a huge expert panel from several groups, which is eUROGEN, which is ERN, which is EUPSA, and from several countries all over Europe, as you can see here. And we want to complete anorectal malformation guidelines on these sections, which are diagnostics, treatment, care organization, follow-up, transition care, patient communication, and communication between healthcare providers. And I just want to stress that we have 2 individual sections on the follow-up and the transition of care, which is in our view very important to improve the quality of care in anorectal malformation within or throughout Europe. So thank you very much for your attention, and I want to hand over to Dalia now, who's going to cover the patient's perspective on transition of care.
Thank you, Jan. Thank you very much for your presentation. Very interesting. I will be talking about transitional care from the patient's point of view, of course. I have no conflict of interest. And just to say that for the healthcare provider's point of view, transition can be said that it is a planned process to move patients from children's care to adulthood care, but it implies other priorities, like the identification of the priorities, the analyzing the issues to be taken into account, to plan a program, how to do the transition, to implement this program, and to evaluate if the program is working. So it's quite a lot of work from let's say for the hospitals and for the departments to organize a transitional program. However, what that means for the parents and patients, first of all, it means that, of course, the patients will not be seen anymore by the same doctors, by the same surgeons, and will be going mostly to another institution, and we have to deal with different clinicians. But this can be, let's say, something natural in life, but of course, in adolescence, where it is a very difficult period of time for the patients, they have also other problems because they can be influenced by impaired physical abilities, pain, medical issues, or forced dependence on the mother and on the father. So it is very important that to transfer them in a very soft way to another adult carer, let's say. So we know that the short-term outcomes in pediatric stage are those that are listed here. We just added allergies at the end because we know that latex allergy is one of the allergy that is shown more and more frequently in patients who underwent many surgical procedures. And these, of course, these issues are dealt routinely, and they are reported in the studies, in most of the studies, and managed by pediatric surgeons. But what happened in the long-term functional outcomes that may continue into adulthood? And we have still another long list of problems that the patient may encounter when he is adult or she is adult. And we also added a plastic surgeon because, of course, some patients reports that they have problems in the fact of that they have scars in their abdomen and they don't like to be seen. So each of these issues have a big impact on the daily life of the patients, and for each of these issues the patient has to find the right let's say clinicians expert in this field, in the field. So in 2015, the patients organization dealing with anorectal malformation within the ARMNet consortium have asked, because Stefano Giuliani was working at that time on this issue, asked Stefano Giuliani to help us in working on a consensus, on a general consensus. And we have actually divided this paper in 7 domains in which we define the goals of the effective transitions, the needs of the teenager and the adults, which were not known till then, the tools to evaluate the problem during transition, the timing, 12 years, 14 years, 18 years, in each country the timing was completely different. And most important, the patient preparation, because the patients have to be put in a way, they have to be autonomous, they have to be empowered, and the parents' preparation, because the parents have to switch from the caring mode into a coaching mode. And then we defined also what was the relationship, the cooperation between the adult carers and the pediatric surgeons. But I saw in literature what there was in the latest publications, and I found this article by the Norwegian and the Swedish group, in which participants underlined that their present lack of knowledge of their condition, as well as the generally low level of knowledge of anorectal malformation in adult healthcare. Many participants expressed a wish for improved knowledge and understanding of their condition, for example, for bowel function, fertility, genetics, and they described knowledge as a way to empowerment. So it is very important to empower the patient. It is very important to have the patient to be autonomous and to know about their own problems and to give them the possibility to express it in an easy way. So transition is not an abstract concept, it is a need. So the patients' organization again were asking themselves how transitional care is handled around Europe. You have to think that we have between the 3 patients' organizations more than 1,500 patients members who are over 18 years old, so quite a big population. And therefore, we decided to have a survey among ERNICA, eUROGEN, and ARMNet healthcare providers. 45 out of 72 centers responded. And it was very interesting to see these graphics, because as you can see here, the problems that the grown-up patients reported to their carers, let's say, were just like problems of bowel management, gynecology, gastroenterology, because Hirschsprung was added, urology, etc., but not mainly colorectal problems. So I suggest to those surgeons who always tells me we don't have the possibility to do a transitional care because we don't find a colorectal surgeon, that this is not what our the result of our survey showed. So also another result, a very interesting result, was that the study suggested that the structured program for transition, as defined by a written document, the presence of a specific coordinator, and the delivery of written information was still missing in the vast majority of the hospitals. Only 6 healthcare providers had this documentation. And so we asked ourselves, so what is happening? Where are the best practices? Let's go and see them. And we saw that there is a very nice program called Ready, Steady, Go from the UK, in which they divide for each age a certain kind of, let's say, program for transitioning, for preparing the patients to the adulthood care. And there is another very interesting program, which is the Dutch one, which is called Stand on Your Own 2 Feet, and which you can also go and see that. Of course, I'm not going to get into the detail of each program, but just to say that they are preparing adolescents for adult life and adult care. So is this an expert between, is this a meeting between experts? Yes, because the clinician is an expert of her own, the adolescent is an expert for her disease, and the mother, as we said, has to step a little bit further back to listen what they are saying, but not to intrude herself in the communication. So we understood that in order to have a good transition between surgeons, healthcare provider, let's say, and the patients' organizations and mothers and patients, a cooperation must be sought. And this is the only way to improve a transitional care. And this is the only way in which we think it can work if we work together. In fact, by seeing this paper on it is a systematic review which identified 10 studies. It shows that to have strategies of a successful program for transition, it should be included. Patients should be included, patient education and transitional clinics in the program. So my take-home message is that you have to start transition early enough to invite adult experts in your consultation clinic, but absolutely, if you don't have the possibility to do that, don't reinvent the wheel. I mean, I'm sure that there are other pediatric surgical units in your country where you can send the patients for transitions, that they have already a transitional program. And you have to start a pathway to enhance independence of your patients, tailor this transition pathway to each of your patients, because of course we cannot talk in a general way. You have to most likely nominate a case manager, because I guess that you're all very busy, and explain them what they may experience during their visits, and especially summarize the history of the patient's malformation. But mainly, it is important to teach your teenager how to read their medical records, to adhere to medical recommendations, to understand their malformations. Usually, if you ask them if they know what they have, they usually cannot explain what they have. They just say that they are incontinence. But it's like they don't know what happened to them unless they say, yes, I had 3 surgeries, but they don't know what kind of surgeries. And especially whom to call in case of emergency. But don't forget that there are patients for life. Thank you. I lost you, I think. No. Here I am. Paola, we cannot hear you.
Okay, so that's again. Okay, thanks. So good evening, everybody. I'm Paola Midrio, working in Treviso, which is one of the referral ARM center in Italy. for anorectal malformations and colorectal pediatric problems. So I'm very grateful to my friends who previously showed how strong is the need for transition felt among this special group of patients. And we are going to see it in practice. I'm going to give you some practical examples of which kind of patients we are dealing with. As Dalia pointed out already, there are a list of problems that we are used to deal with during adolescence, but then a number of new problems may rise later in life, for which we as pediatric surgeons are definitely not prepared to deal with. So we need to look for help and to help our patients to look for the best care in the adult service. So I'm going to give you some example. These are all adult people from my service. So this is an example of a trivial mucosal prolapse, very easy to be fixed. This older lady also came to our service for mucosal prolapse, but is it really a mucosal prolapse like this one? Of course not. She clearly had a mislocated wide anus. We don't know the original malformation. This is one of the problems with these old patients, because the initial information are basically lacking and they rely on what the parents have told them when they were a child. So it's difficult to reconstruct what was the original malformation. This can pose some problems in helping them. For this lady, she got into a more difficult management of her bowel when she turned into menopause. But before having a surgeon taking care of this, we went through conservative bowel management with the stomach therapist, and that was successful. Clearly, in an old lady, there is a little space to relocate the anus to make a more comfortable looking. So we have to restrain, and teach the adult colorectal surgeon to restrain from their classical operation that they do for typical rectal prolapse, because in these patients, the ERN patients, the anatomy of the anorectal canal is not normal. So the type of surgery that the colorectal surgeons usually look for normal patients are likely not to work. This other woman instead had a real complete rectal prolapse that was impeding her from normal urine outflow. So in this case, we had the colorectal surgeon performing with us a laparoscopic rectopexy, inserting a partially absorbable mesh between the rectum and the vagina, and this was successful. This other young man, he reported to have a simple perineal fistula, but he was struggling with a very tiny anus. And this was an easy task to do an anoplasty, but of course he was then put on regular bowel management. These young adolescents, he was 16 years of age, complaining of repeat urinary infections and stranguria. And so when we looked at his images, it was clearly that there was a posterior diverticulum from the urethra. Indeed, he had a laparoscopic treatment of rectobulbar fistula, which we know in many cases can end up with this kind of problems. So together with oops, what happened? Can you see my screen? Yeah. Together with the adult urologist, we took care of this with an anterior perineal approach. While in this adult man, he was a 55 years old man in a list for kidney transplant. And while he was in for the workout to check for integrity of the bladder and urethra, they found this big posterior diverticulum and stenotic urethra. So in this case, the adult urologist took care of the diverticulum with the robotic approach, and in the second time also the urethral stenosis. This young lady, she had a rectovestibular fistula, and she was having quite a normal life, except for being bothered during the sexual activity by this large ectropion that was corrected by the plastic surgeon with a very nice final appearance, and she regained a good quality of life. This other unlucky girl, she was born with a long cloaca and a missing inferior leg. Everything was fixed except for the leg. She's wearing a prosthesis, and she's catheterizing every day and doing bowel management, but she was apparently dealing with that. When she turned adult, she was very much bothered by the aspect of her belly. She did have indeed a prune belly, and that was her major concern, instead of not having a leg or have to do the catheterization or bowel management. So the plastic surgeon again took care of her and did a very nice final job, and she was really pleased by the plastic surgery that was done. And then we took care, unfortunately, together with the colorectal surgeon, of these two patients, a boy and a girl, that unfortunately have a mucinous adenocarcinoma while they were in their 30s and eventually died. So we do recommend now in the follow-up to have an assessment every 5 to 10 years of the rectum, because these cases are very rare but are likely unreported by the adult populations. And then I'm sure that among the audience, some of you have encountered a situation like this, in which you have an adult girl with an untouched rectovestibular fistula that was correctly with the regular PSARP. So while the patients are young and up to adolescents, certainly we are the case manager of these patients, and we are the main referral person for them, and coordinate all the other professionals, or even with the patients' associations. That is really important, the management of this patient. But as soon as they turn adult, they have other need. They have the need to work, to form a family, to have children, and they might have other problems that Dalia has already pointed out: psychological problem, urological problem, physiotherapist problem, and why not the sexuologist. So these other professionals need to come into the field for the care of these patients. And we, as pediatric surgeons, certainly are one of the referral person, but we basically need to coordinate our colleagues. So just to give you an example how works our referral center in Treviso, out of almost 300 ARN patients, now 1/3 of them is turning adult, is older than 16 years. And as Dalia has shown in her work on the European survey, these are the active problems among the males. So mainly bowel problem, but also a large component of a urologist problem, which is also regarding infertility, prostatitis, or epididymitis, for which we need the adult help. And regarding females, certainly the gynecological area takes a large part of the cake. And again, there are other problems, including the plastic surgery, that needs to be taken into account. So in practice, what we do is to start very early, as Dalia said, shows in the Ready, Steady, Go program, to promote independence of the patients, which is usually already autonomous for the catheterization, but is unlikely to be autonomous for the bladder management, because the patients at this, the parents at this age, still are caring and not coaching the patients. But then along the years, we start to talk more to the patients, and the parent sits in the back, as shown in the from Dalia before, and we start to talk to the patients, saying how it will probably be the transitions, and why when they are sort of almost adult, we invited the colleagues from the adult services to visit the patients with us and to present them the case. And then finally, when they turn adult, we were used, and we are sort of a transition also from paper to more technological advances. We were used to release a summary of the history of the patient, so the original malformations, the list of surgeries, and the active problems. Now, with the help of AIMAR and based on the idea of one of our colleagues, Alessio Piniprato, we are transferring these informations in 2 languages, Italian and English, on a USB that the patients can carry with him while he's traveling for work or for leisure around the world. Of course, these are some steps that help also us to remember when to start and what to do at each age, but it depends very much on the patients and the parents and the family. So each step needs to be flexibly managed at any time. Thank you.
Thank you very much. If there are any questions, please type them in via the question field. Then I'll send them to the presenters. We did not receive any questions yet. So in the meantime, I'd like to tell you all that this webinar has been recorded and will be available on both our GoToWebinar platform and the YouTube channel. And the links will be sent tomorrow. All links for the previous sessions are on our website, as are the details of the forthcoming webinars. We have a YouTube channel you can subscribe to. You can easily find the past webinars on their playlist.
Luz,
just look.
I have
Yes.
a question for the audience, if I may.
Yes, please.
Okay, I would like to know how many of how many of the people in the audience are doing a transitional care, or they are sending their patients to other institutions for transition.
Okay, thank you. In the meanwhile, we have a question. If you could please share your protocol for transition. I think that's for Paola.
Yeah. So this one?
I'll make you presenter again. Wait a minute.
Okay. Can they see it?
Yes, now you are presenter.
Yeah.
Yeah.
So these steps come from the continuous talking with the patients, the parents, and the patients' organizations, and among colleagues, of course. And we learn, as a pediatric surgeons, we have learned and we keep learning very much from the questions that come from the patients' organizations and from the parents. So it's not something that we impose, but that we have learned from their questions. Ian, can I ask you, do you have a similar protocols?
Yeah, we have a similar protocol, and if you look through the protocols which are at least published throughout Europe, I think the steps are quite similar all over Europe. And I wanted to stress that we will use this and all the other existing protocols to gather the information for the European guideline. And I think there will be lots of discussion because not everybody has a gynecologist who's interested in rare diseases, and that's going to be probably the most difficult part, to find people who are able to cover the transition. But all these protocols which are available will find their way into the guideline development process.
And as Dalia always say to our meeting, is easier for surgeons working in a general hospital where adult and pediatrics are close to each other, instead for a children's hospital that really needs to change, sometimes change city or change building, and it's more difficult to have a transition if you are far away from your colleagues. But of course, everything can be done now, even online.
And then, Paola, I must add that there are best practices already in Europe. I mean, that you can adapt to your country, you can adapt to your institution. I mean, the will is already there, as I always say. There is nothing to reinvent. There is always to adapt it and to improve it, but the will is there.
And as long as if you don't have a healthcare professional who's covering whatever the patient needs within your region, you can still send them over regional or even national. So that, I think that's the most important part of this whole transition process. You don't have to send the patient next door. He can go to another gynecologist, for example, or sexologist who has experience with rare diseases and anorectal malformation, who's not from the same city.
Yes, as long as you go with them and explain beforehand, and not just send the patients, knock the door, because then
exactly
they will be, yeah.
You are, as you said, we are the case managers, and we will stay the case managers probably for life, for the whole life of the patient, even if he's an adult.
And meanwhile, we have a question from Lara Steintler, who asked, who are the doctors that can follow up adult patients on bowel management and incontinence? Are they also experts in his malformation?
Usually not. That's the problem. That's a problem. But the stoma therapist, people from each referral center, hospital, has a stoma outpatient clinic, because they are used to work with people that has permanent ileostomy or colostomy, and they also teach how to do the intermittent catheterization. So if you look for these people, they are very helpful, also suggesting different devices, because they know the market much better than us surgeons, and can suggest a lot of tricks of management of the stoma, but at the same time of a transanal irrigations, for example. So those are some of the people you should look for.
Yeah, same in Germany. So we take the stoma therapists as well, and they are able to even go to the home of the patient and introduce bowel management systems. They are they know the Malone stoma, they how to use or utilize the Malone stoma, and that's very helpful.
Yes, same for Coloplast, for example, or for the Ostomy Association in Italy, they know exactly what to do.
Yeah.
Got another question from Pim Sloot, who asked, do you have a regular follow-up after 18 years, or do you wait for symptoms or complaints?
I take them up to 18 and discharge only those who are perfectly working. But if there is something not perfect, at least we list the problems that are active. Then of course they are adults and they can decide whatever, but the list of problems is there for whenever they need to be taken care of.
Yeah, same with us. We follow regularly until the age of 18, and if we see there's an ongoing problem, we regularly see them in adulthood as well, and we are always, let's say, available if transition isn't working as we expected.
And you might be called even from the obstetrician, because that sometimes they ask you, is a C-section indicated? And you are a pediatric surgeon, but if there is any perineal issue, definitely a C-section is indicated. So be prepared to be called from different colleagues, which is good, because that means they think before doing, which is very good.
And what is also very, sorry, yeah.
Yeah, we've got a message from France, and they also do it until 80 years, and sometimes longer if there is a syndromic disease.
Yeah, oh yeah.
Sure. I think further there are no more questions, but a few comments on everyone who thinks it's very important to educate your patients. So I think the message came through very, very good. If there are no more questions, I would like to thank you all for your very nice and clear presentation. I would like to thank the audience for listening to us, and wish you all a very good night.
Thank you.
Thank you.
Thanks everybody. Thanks for listening.
Thanks everybody. It was a very nice